Hello, Don here. Welcome to Podiatry Practice Mastery, where we're helping you get your practice to the $2 million mark and beyond. This is a recording. I'm going to talk about a Monday here in my office. So this day I had, her name was Duda. She came. Duda is a podiatrist in Brazil. So she came and shadowed me for a half day, which was really nice to have her in. If for those of you who don't know, I did live some time in Brazil, so I speak Portuguese. And podiatry in Brazil is kind of like how it was here, I don't know, 50, 60, maybe even more years ago, where all they can do is like nails and calluses, and they're trying to increase their scope of practice, but it's still kind of limited. So it was nice to have her visit and things like that. I have a couple of podólogos, they call them, that are working here as nail tech. So basically they went and got back a nail tech, and then they do some type of nail tech work, but a little bit more, and they try to pull out ingrown toenails. And then when things get kind of dicey, they send them over to me. So it's a good kind of referral flow, since most of these are Brazilians and they tend to be more self-pay patients. So it was nice having her. There was a patient that came in. This is something I've mentioned a few times before. They had a retro-onychia, so they had like kind of swelling, pain at the base of the nail. If there's no pus in there, I tend to pull those off, and I tell patients that they'll grow back wavy. If there's redness, I tend to call it an IND. If it's no redness, then it's a nail avulsion. So, and it's just something to remember when you are doing your billing. I don't always talk about billing stuff, but if there's redness, IND tends to get reimbursed more than just a regular nail avulsion. Okay, so my MVP patient, this was one of my first patients of the day. This is a 45-year-old man. He came in and he had bilateral plantar fasciitis, and he had had pain for quite a while. We did an x-ray. X-ray was kind of helpful, but was really helpful was the ultrasound. So I did an ultrasound, showed that one side was thicker than the other, did my normal things, my night splint, foam rolling, morning stretch. And I said, okay, so the best way of treating this is with Shockwave. I really didn't think that he needed the amnio injection, but I think it's the Shockwave. And so he set up those 6 sessions of Shockwave on the first visit. Usually I'm doing a 2-step approach where they're doing the initial treatments, and then I see them back in 2 or 3 weeks. But I just said, hey, if you want to just speed this thing up and get rid of it, really the best way is the Shockwave. So he's going to set those up. I did not start the first day, only because I didn't have time. Next was this 20-year-old young man. I was a third opinion for him. He had bone marrow edema in his tibial sesamoid. Question bipartite, question sesamoid fracture, just been there for months and months and months. He's doing this like elaborate offloading with a walking boot and dancer's met pad and all these other types of things like that in his shoe. Really frustrated, didn't really have a plan, and we did 4 sessions of focused or not, or either broad focused or regular focused Shockwave, and he's already starting to feel better, which I'm pleased with. He's going to go back to school, so I'm going to see him back in 6 weeks, and I told him I might do another session. Sometimes with fractures, I do 4 sessions instead of 6. I did it in his case mostly because he had to go back to school, and I did advise him he might need a couple more based on how he's doing. Another MVP patient. I was a 4th opinion for this one. I'm tending to get a lot more opinions. I'm not sure why. I think it could be we have a good SEO team doing a lot of content about Shockwave. And this patient, she came from Boston, and she had plantar fasciitis. But it's interesting. She was she's a hairstylist, and she was walking on a treadmill in an incline for like 45 minutes, and she never walks on an incline. And she started to have some Achilles pain, then some plantar fascial pain, and she did have pain to the plantar medial heel bilaterally. But the issue was it's only been for 2 months, and she never had it before. So when she went and saw another doctor, I think it was an orthopedist, they did an ultrasound. They said the fascia looked normal, and I agree. The fascia does look normal. Like there's no fascial thickening yet because it's only been 2 months. It usually takes more time or recurrent episodes for the fascial thickening to happen. So I did talk to her about the treatment, and I do think the best treatment for her would be this bilateral plantar fascial Shockwave. So she's going to get bilat Shockwave, and we're gonna see her. So those were my MVP patients. Other patients of note. Some other Shockwaves I did. There was a number 4 out of 6 for Achilles tendon bilaterally, number 2 out of 6 for posterior tibial tendon. There was a pes anserinus for like the peroneal tendons, number 5 out of 6. Posterior tibial tendon 1 out of 6. Plantar fascia 1 out of 6. And so those were kind of the the main ones for the day. Okay, so that was my Monday. Go back and talk about next one would be another Monday. This was a day here. I'm going to talk about some of my favorite ones from this day. This is the Sever's. So Sever's patients are responding really well to the Shockwave. Just so you know. Now we had a big discussion in our office. Not big anyway. I talked to my partner. he saw this patient. He didn't feel comfortable doing Shockwave, but I feel pretty comfortable about doing it, especially going to the conferences. There's really no problem with growth plates, and I do find that it helps the Severs much quicker. So this was number 4 out of 6 with the Shockwave. There's another patient, number 5 out of 6 for plantar fasciitis. And then there's this patient, I think I mentioned before, he has some scarring to his plantar fascia after having a spur resection and just some scar tissue. It's been there for years. My MVP patient for this other Monday was this Shockwave patient. So he has a pickleball like business, and this gentleman, he had these overlapping second toes. So I amputated one second toe and then the other second toe in the office, and then we did Shockwave for him to get rid of his Achilles tendonitis. So he's doing better, getting better. It's just kind of a slow process for this patient. So that was a Monday. I'm just trying to get rid of I have a lot of these papers stuck in my trying to share these with you all. This is a Friday. One of my MVP patients. This was a routine patient. And so one thing I want to mention, so routine doesn't always have to be routine. I think we have to always keep our eyes open. There's a lot of things that we can offer our routine patients that can make them from a low value patient in terms of production. I'm not saying that they're anything about them as people, but I just in terms of revenue production. So there's a lot of additional procedures we can do, like Lipizana, small little procedures in the office, flexor tenotomies, even simple prefab inserts. You can do, if you do diabetic shoes, we don't do diabetic shoes. You can do diabetic shoes, ABIs, things like that. This patient specifically had a exostosis on the 5th digit, and so we decided to set up that exostectomy in the office along with doing the routine. So they kind of complained about this. I say this is a pretty simple thing. This is one of my favorite things to do in the office. There was another patient that we teed him up for posterior tibial tendon pain, doing 6 Shockwaves. We gave him a cam boot, and we talked to him about possibly doing an amnio injection. I'm finding now the tendons that I'm kind of recommending more of the amnio isn't so much for the plantar fascia. It's more for like the posterior tibial tendon. I find that's the one that's really injured the most when I'm treating that, when I'm looking at that on the ultrasound. There was another patient that came in. I want to talk about my failures too. This was a patient, 46-year-old female. She had bilateral plantar fasciitis. She tried the initial treatments, and I feel like she would best benefit from Shockwave, but she declined. So she said no, and that's fine. So what I do with her, it was due to the price, and I said, that's fine. When I talk about price, I always say there's a couple of options. You can do care credit. You can which is like something they can pay over the next 12 months. You can kind of pay as you go, or you can get a discount if you pay it all together. Or if you can't pay, I just push them out for like 2 to 3 months, because I doubt that the pain is going to get better over the 2 to 3 months. I'm not sure if they go to see anyone else, but that's kind of what I say to them. Another patient was a 72-year-old female. She had bilateral plantar fasciitis and equinus. So she got my Pelto special with 2 night splints, foam rolling, morning stretch, and things like that. Okay, so this I'm trying to read my handwriting on these papers, and I can't always. It says I ran out of something. All I know is that when I run out of things in the office, I get a little perturbed with my staff. I always try to keep enough, especially if you're trying to provide things for patients. Okay, this is a Thursday. I had I had some ideas of I was talking about like urgent foot care clinic, and I was trying to work on giving out these referral cards to patients. So I keep on trying different types of things to get more revenue. in the office and more referrals. The urgent foot care cards are the things that seem to be working. I put tracking numbers on there, so I'm going to hopefully be able to track if people are actually calling. I recently went to one of the PT places, and they are actually handing these out, which is nice. I can see them in their waiting room. Okay, and my MVP patient, this was a patient that I had a right MRI follow-up, 57-year-old man, and he had bone marrow edema in his foot. And so because of this bone marrow edema, we set up 6 sessions of Shockwave. So he had pain for a long time. MRI made the diagnosis of the bone marrow edema. I couldn't see that on X-ray. And one of the better ways to get rid of the bone marrow edema is the Shockwave. Next patient, there was actually, least valuable patient. I like to share some of these too. This is a flexor tenotomy follow-up. So really, there was a long global for this, and I saw the back, and I was able to get an X-ray. So I think one thing that also perturbs me sometimes is when I have them come back and they don't get the X-rays, and so really, then you're not doing anything. You can't get an X-ray. You're not getting an office visit. So I always make sure I can put these into a 10-minute slot. Next was an 89-year-old man. He developed like unilateral, like peroneal kind of pain and swelling around the ankle, and I ruled him out for a DVT. And he did 3 sessions of the Shockwave, and he's doing much better. He's completed those now. And then there's another patient that came in. She had a AVN to the right second med head, and we did an offloading orthotic. So that also works well for the Shockwave. I don't think they wanted the Shockwave. And I did a couple of orthotics this day. And there was a patient that came in that had a very small fibula fracture on an X-ray, very mild. So they got a cam boot and fracture care for them. Okay, next day here. It seems kind of repetitive to me here, but hopefully this is helpful. There's a patient that had number 4 out of 6 for Shockwave, and then we did an orthotic for that patient. There was a patient that had a foreign body, and I was able to remove that foreign body with an ultrasound. It was a piece of wood. Next was a number 4 out of 6 for plantar fasciitis. This patient, I got a no from. They had second toenail fungus. They decided to do EBM, the Tosalin. I don't have Tosalin in the office. I know some people swear by it. I just don't want to change currently, so I'm using it whenever I decide to prescribe it. It's through EBM. I probably don't make as much with it, but I'm just testing it out. I did offer my largest check, but I got a no from them, so I always like to tell you when people say no to me. And another patient that came in for fibroma, and they decided to do the EBM fibroma stuff, that cream, and then they're going to do Shockwave, 3 sessions of Shockwave. Okay, this is a Friday as well in the office. Flexor tenotomy, digits 2 and 3. They had an ulcer to the right distal tip, and I gave them a collagen. I think collagen is one of the best things I can give. It's that Amerigel collagen. Really works well for my patients. Least valuable patient, this was a right peroneal repair. I've been seeing some of my colleagues' patients when they were out, so this was a least valuable patient because it was post-op. We did get x-rays, but that's about it. Another patient where I offered Lipizana, and there's another patient that got a Cariflex, and there's another patient that got an orthotic. Okay, that's that day. Another day, I'm going to go over, this was a patient. I've been seeing some of these post-ops when my partner was out on paternity leave. There was a fracture code patient, 4th met fracture, got a cam boot. You're going to see them in 3 months to see how they're doing, and then orthotics, and kind of repetitive here. as one day kind of runs into the other day. Okay, and I'm on my last piece of paper here I want to go through with you. So, finally. Someone asked me a question. How do I set up my fungal kits? And then someone also asked me about my Lipizana process. So let me go over the fungal kits. So fungal kit, you can put whatever you want in. I piecemeal it together. What I talk about in a fungal kit is I have some type of a biotin product, so you can have whatever biotin. I just think it helps the nails to grow faster. And then I have a UV light and then a shoe spray. and then you can use a topical if you want. What I find, a couple of things, is I find if you explain it well to the patients and they understand the process, this is why I use my treatment sheets when I give it to them. It basically tells them how to use it. And it's not just giving them the product, it's like explaining how they're going to use it. And I do this for, I know it sounds real simple, and I know we feel like our patients know what we expect, but if you're really clear, versus having them doubt, you're going to have a lot less questions, and they're going to follow through with what you recommend. So for the fungal kit, it's pretty simple. They're going to take the terbinafine, and they're going to take the biotin, whatever the biotin product. I have them get 2 bottles, which will last about 4 months. And then I say, okay, once a week, you're going to do the UV light. And then, once a month, the UV light. Once a week, the shoe spray. And then I add a couple of other things that I think are important. They're going to wash their socks. They're going to use bleach in their shower and stuff like that. So I keep it real simple for them, but like, this is the process. This is what you do. This is what you can follow. This is so it won't come back. And this is how to get rid of it. So I do that with that. And I also do it with my Pelto special. So I have them do the morning stretch before they get out of bed, put on their UFOs, do foam rolling for 3 minutes in the morning and night, and then use that rest splint or the night splint 3 hours a day. So anytime you're doing these packages, I think it's important for us to be really clear with patients of how they should take it, how they should use it. And then I think I have explained already the Lipizana. I've done it on 2 patients so far, and it's one worked, one kind of didn't work in the heel, and so I have to keep on kind of offering it to patients. Okay. Other things from this day, I'm trying some of these neuropathy, this EBM neuropathy things. So for neuropathy, we have the Q10s if they're diabetic. If they're non-diabetic, I don't really have many good things for that. So I'm trying these supplements for that. There's another patient that got a orthotic. There was another patient that came in. This is referred by another podiatrist, and he had left plantar fasciitis. So I like it when other podiatrists don't have the type of treatments that we have, because they can send them over. Because really, if patients aren't getting better with cortisone and orthotics and things like that, I'm happy to see them, and then I'll just do the Shockwave. And so this is a colleague of mine. Another MVP patient was a 3 out of 3 Achilles, and then a right exostectomy. We're going to set it for this patient. And there was another patient that had midfoot arthritis, and they're number 2 out of 6. We're doing that for midfoot arthritis. So those are the days. I hope you guys found this beneficial. A couple of things that I'm working on. I'm going to do a lecture at Greendale Physical Therapy, which is a physical therapy place around here. So I like to do talks. I don't do them all that often because it takes me out of the office. But this is one on like a Saturday morning. It's on at 10 a.m. So I think that's a good time. And then what they're going to do, just in terms of the marketing of it, I'm going to send it out to my list. I'm putting it on the door so the patients can see that. Meaning when they check in, they can see that I'm doing the lecture. Even if they don't go, I think it kind of breeds a little bit more credibility, right, to what we're doing. So I think, and then I'm also sending it out in my e-newsletter. And this physical therapist that's a friend of mine, he is going to send it out to his list, but he's also going to do some postcards and send them to the referring doctors, the primary cares. So it's just a kind of a way to get the word out there. But if you want to talk about like, okay, what do you do when you do a talk? I think it's real important to, whenever you do something, you repurpose it. Okay, so let me explain this a little bit. So if I'm going to take the time to prepare the slides for a talk, I'm going to practice the talk, and then I'm going to do the talk. A lot of times what I can do is I can do the talk before and record the slides like a screen share, and I can put it on YouTube. I can send it out after I do the talk. I can send out the actual recording of the talk, either them recording it or me re-recording it, to my list afterwards. So they can get that benefit. You can put it on a web page on your website about that talk, and you can put like so if they get their email to get access to that talk. So call it like a webinar. So there's a lot of different ways you can do it. You could even take this webinar that you did, and you can send it out like in a postcard. As I've been working on these like postcard ideas to primary cares, you can send this out with a QR code so that the primary cares, if they're interested in learning kind of what really works, because what the title of this lecture is plantar fasciitis and Achilles tendonitis, what actually works. So I'm going to be spending, as you can imagine, most of my time talking about Shockwave, but really about making a proper diagnosis and why some of these other types of treatments don't work. So I'm just I like you to think about these ideas of whenever you do something, you want to try to repurpose it. I think that's very beneficial. So even when I'm in the treatment room with patients and I can record videos, you can then repurpose them. I think that's one of my biggest takeaways when I had a podiatrist, a podóloga from Brazil visiting. They recommended I get the new Ray-Ban glasses with the that could record videos. I have not done that yet. If anyone wants to give me a gift, you can certainly do that if you found this really beneficial. I'm probably going to get them just so I can record the content with the glasses, because you're taking something you're already doing, which is seeing patients and helping them and explaining things. And if you could either yourself or even have a staff record you, that's going to create easy content that you can put online. Because if you're sharing it with patients, you tend to be at your prime. So I always say that if you have a doctor that really doesn't like to make content, they're probably very, very good clinicians. And so what you can do is you can just go and have a staff record them as they're explaining things to patients, not showing the patients, of course. But this can really make great content for your little like sound bites for your website. Even can help patients out. So this is a good recommendation, easy recommendation for making content. If you struggle once a day or once a week, have some staff follow you for a few hours. You can make a lot of pieces of content in that time. Okay, and then you just put it up online. You add subtitles, all these other things. Okay. Once again, hope you guys found this beneficial. And if you want to learn more or have any questions, shoot me an email down at podiatrypracticemastery.com. I have the two beta offers. One's going to be on a practice audit. I had a doctor ask the other day about doing this audit with me. If you're interested, let me know. It's kind of almost free for now until I put the price on the website. Once I put the price on the website, I think I'm going to charge, I don't know, maybe $500, $800. I think more people will do it when you actually charge, because I don't know, I think people don't do anything when it's free. That's one of the big struggles. And then there's going to be a $1 million implementation group, which is like, okay, I hear you down on how to get to the $1 million mark, but I'm going to have a hard time implementing it. I think a lot of us have a struggle kind of actually making it real. And so that's why I'm putting this together, this implementation group. If you're interested in that, let me know. Okay? Talk to you next time.